experience with MODA and OEB's presence. So it's this, things are never seamless, but they're probably as good as they can get. Yeah, and in fact, I see Kirsten, you've joined the group. It's Kirsten Staveland is the person who is going to be working, filling in some of the roles. And again, all that will be introduced this afternoon. Okay, Robert, I see you've joined. Jeff, are you here yet?
Jeff called in. He'll be a few minutes late.
Okay, thanks, Ollie. So I'm going to call to order the June 7th, 2022 OEB Strategies on Evidence and Outcomes Work Group. We are meeting remotely. And if you have your agenda, it's on the screen. Shows that we are going to focus on dental. Both will have a report from Willis Towers Watson in regards to the annual dental experience, that they give us a report, and then we will have each of the dental plans talk about, give their own report in regards to the co-impact update. So that will take us through till we hit a break, and then we have another presentation from Willis Towers Watson on our additional cost tier, taking us back to its inception, and will give us some recommendations of how to proceed with this intervention that has been in place for over 10 years. Interestingly, we have, I think the first time since I've chaired the SEOW, we have public comment, and we'll talk about that. So that is the agenda for today. The first agenda item is the May meeting synopsis, and that was included obviously in the packet. Is there any issues or questions or corrections that any of the committee would like to make? Otherwise, I'll accept a motion to approve.
I move to approve, Robert.
Thank you, Robert.
I'll second.
Thank you, Bill. All in favor, say aye.
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 Opposed. Thank you. So it's approved. The action items that we had included a request for us to look at OEB membership, and Robert had raised a question about why there had been what the impact or meaning of the decline in OEB membership was. And Mark Jameson from Willis Towers Watson was going to get back to us. Ali or Damien, did that happen? Or is that something we're waiting on?
Still something we're waiting on.
Okay.
At least I haven't seen it, but
Okay.
you know, in general, having kind of tracked OEB enrollment over the years, it always starts out at a much higher number in the first month of the plan year, and goes down in subsequent months. It's almost like clockwork. So so that could be the case. We actually meet with the OEB stakeholder group later this week, and we can talk to them about it as well.
Super. So if when we get that, if we can just send a brief email to the SEOW committee, and the distribution would be helpful. The under the medical.
Mark is on the phone, Tom.
Yeah, I'm here, and I just wanted to say, Tom, we did get a response back, sent it back to Glenn, and I think that either he can distribute that, or we'd be glad to forward that onto the rest of us as well.
Ali will work with you've done your part, so Ali and Glenn will get that out to the rest of us.
Great.
Glenn happens to be on vacation today, so it's
okay.
So otherwise I'd be asking him directly. There were under the medical performance guarantees, there were 3 different action items in regards to requesting data, and then there was the telephone visits. I think I saw that's under item number 5. I believe I've seen that response from Kaiser Permanente. The other 3, we will, I'll follow up with Glenn when he's back and get that information in an organized fashion out to SEOW. Any other questions about the minutes and the synopsis from May? Otherwise, we'll move ahead to the annual dental experience report. Brad and Mark, you're on. Thank you.
Hey, thank you very much. So are we ready to start, Tom?
I think we are.
Okay, so, really quick, the purposes of this report is to review our key trend drivers and plan performance, including our demographic information, our cost information, kind of on a per member basis, as well as utilization. We generally start with an overview of the recent plan changes, kind of walk through a few of the additional key items in an executive summary format, and then dive a little bit deeper into the detail. So kind of thinking about our plan changes in the 2019-2020 plan year for Delta, we did have some enhancement of additional preventive services, and we did freeze the incentive benefit level, even if no preventive visits happened during the 2019-20 plan year. And that, of course, was due to low utilization during the pandemic. Looking at 2020-2021, the prior plan year, in Delta, we did put in a new program to identify hypertension risk, and then a couple other little small things, including carry forward of that incentive freeze, again, due to the pandemic level and concern that folks were not going in to get their preventive care and not wanting to penalize them due to the pandemic. So in general, overall, we saw membership drop just a little bit, while costs have increased significantly. As we go through this report, you'll notice large increases in cost and in utilization in general, and that really is due to that significant period of COVID claim suppression that we had in the 2020 plan year, and a return to that, but not quite to that in the last plan year, closer to the pre-pandemic levels. Right. With that, we can move on to the next slide here. And so we've got, taking a quick look at our population demographics, they continue to be largely stable. We've got just a modest increase in average age. Again, family size fairly stable, percentage male fairly stable. We do have a little bit of a larger changes in the smaller Kaiser and Willamette populations. And then looking forward to total spend, if we move kind of over there to the right-hand side, we do see a significant increase of about 10% year over year. For all carriers, we saw a pretty significant increase in spend from about 66 million up to about 72 million in there. All carriers did see an increase generally in use of services. Delta was relatively flat on the preventive side, and I think that's a really positive thing. We did see a really strong rebound of preventive services during the 2019-2020 plan year. Kaiser still saw quite a suppression during that year, but has subsequently recovered, and we also see that with Willamette as well. Normal levels for all of the carriers. Most notably, Kaiser had quite a large increase in recovery. And for restorative services, Delta really stayed fairly flat during the pandemic and subsequent year, but we did see modest increases in the Kaiser and the Willamette utilization of those services. And we will get into more detail in all of those things a little bit later. But any questions before we move on? All right. So kind of continuing our high level executive summary, we'll take a quick look at cost share. We always like to see how that's changed. The different colors, of course, represent our different carriers. Willamette, Kaiser, very similar from a cost share perspective year over year. We did see an increase in that cost share for Willamette, moving from the prior to the current, going from about 15% cost share to about 19%. All right, looking at the percentages of member exceeding the plan maximums, very consistent with what we've seen in the past. We ranged from kind of a low on the, Kaiser on the low end, certainly with their higher dollar maximum. On the Delta side, the lowest number of members exceeding that plan annual maximum was in the EPO plan, and the highest number in Plan 6, which of course has the lowest annual maximum, the least rich amount of benefits in there. So otherwise, very similar and consistent with what we've seen in the past. All right. And kind of on the lower part of that table, we look at preventive visits in a little bit more detail. We did see for Delta, of course, very consistent year over year. We were at 64% for the prior and 66% for the 18-month and 64% for 24 months. So this is really indicating that folks in the Delta plan are getting consistent cleanings on both a 12-month, 18-month, and 24-month look. Moving to Kaiser, we saw in the prior period there was a pretty big gap between folks in the 12 and 18-month. They have really made a significant improvement in the 12-month statistic, increasing from 34 to 46% of the population getting a cleaning in those 12 months. And we did see improvement, not quite as much improvement, but we did also see improvement for Willamette Dental Group, which went from 37% of the population getting a cleaning in a 12-month period up to 42%. So, seeing that focus on increasing services paying off for both Kaiser and Willamette.
A question. The under the 2021 exceeding plan maximum, I don't see Willamette Dental Group.
Willamette does not have a plan maximum.
Okay, thank you. That answers
Yep.
it.
Great question.
Okay, I had forgotten.
Nope, that's all very good.
Okay. And I
Very good
know that,
question.
and I know that the Kaiser plan has a very, one of the reasons why it's so low is that it has a very high, I think it's 4,500 annual maximum.
Yep. Yeah. Right in that $4,000 range,
Okay.
compared to usually we're sitting at I think our current plans run from around 1,500 up to about 2,300 or somewhere in there. Mark can keep me honest if I'm super far off, but absolutely. And that is what's driving that very low percentage of members reaching the plan max under the Kaiser. And a good reminder that we love questions as we go along. So appreciate that question, Tom. All right. So we can move on to slide 6 and we'll look forward. Now, kind of we looked at what our plan changes were, kind of looking backward for the past couple plans, looking for the current plan year. We know that we introduced some preventive enhancements for Kaiser. We reduced our Kaiser preventive copay visit from $20 down to $0 to really try and drive improvements, and we're seeing that working. And with Delta, of course, we introduced our new, kind of EPO plan with a little bit richer benefit level. We did see some enrollment in that we'll focus on in a little while or connect on in a little while. And Willamette also waived a copay for preventive dental visits, but only for members who have never seen a Willamette dental provider. So looking forward into the 2022-2023 plan year, start with the Willamette. We just talked about their copay waiver program that will continue. Again, just for members who have never seen a Willamette dental provider. Delta Dental, we introduced the Preventive First program, which offers coverage of preventive benefits, without really applying to the annual maximum. And then Kaiser, we had no plan changes for the next year. Just a quick summarization and a reminder of changes that we just talked about at our last renewal meeting. All right, move on to slide 8. Looking at a membership basis, again, our population has been relatively stable. There's consistent distribution between plans. Delta having of course, the largest proportion of membership at 73%, Kaiser at 13%, and Willamette at 14%. And looking a little bit further, a little more detail into here, we see that, of course, the largest concentration is in Delta Plan 1 with 34%, and then followed by plans 5 and 6, and we did have a little bit in that EPO plan at 6% there. Family sizes relatively consistent between our different plan options. We do range from a low on the Kaiser plan of 2.3 to a high on Plan 5. Not totally sure what drives that larger family size enrollment in Plan 5, but not too far off of Plan 6 either. So very close at 2.6. Percent male, not varying significantly between the plans, and average age, some variation. Not unexpectedly, we see the EPO plan with an average age of 32, and ranging up to Plan 6 with an average age of 38. Any question on some of these demographic statistics? Interestingly, that of course we continue to move to even out from a generational perspective. Boomers keep declining a little bit, and starting to see a little bit of uptick even with Gen Z. All right. Moving forward to slide 9, we always like to take a little bit of a historical look back. In the past, this has had very significant impacts as we've changed plan lineups and made material modifications to those. We can see how they change over time. Just looking at these lines, from the 2017-18 plan year up to the 21-22 plan year, we don't see a lot of material changes. A little bit of ups and downs, but nothing significant. A very stable and steady population. The periods that we are looking at in this report are highlighted in sort of that gray shaded box. We have added in the 2021-2022 enrollment results as well. And, not a lot of change, although we do see the little pop-up of the new plan offering from Delta in there, and that's represented by the purple dot in the very lower right-hand corner. So not a tremendous amount of enrollment in that, but we'll see how that grows in the future periods. Okay, we can move on to slide 11. Okay, so here we kind of take a quick look at costs. We're going to look at each of the carriers in turn. For Delta, we can see that our plan costs have increased 7% over the prior year. This is not surprising given our somewhat of a claim suppression in the prior year due to COVID. Interesting that we kind of see that pattern. If we step all the way back, we see modest growth in total cost, and that being the summation of kind of our core plan cost, orthodontia, and member paid out-of-pocket costs. We see that growing slightly, for the first 3 years, taking a pretty good dip in the 19-20 plan year from COVID, and not quite recovering all the way back up, ending at $617 versus where we were pre-pandemic at about $643 on there. But overall, very modest growth over the last 5 years. Okay. Right, moving on to slide 12 here. We can see that for Kaiser, we actually saw a pretty good jump between 2016-17, followed by a drop pre-pandemic. So we had a nice cost decrease there. And then I think Kaiser was probably one of the hardest hit plans, not just for OEB, but in general. Very strict management of services during the pandemic, very cautious. we saw a drop to $454 and a subsequent large increase of 34% up to $634. Again, not quite to pre-pandemic levels, but moving closer and closer toward that. And again, modest growth over the last 5 years, impacted probably by this, continued pandemic claim suppression. But we've seen about 2.5% over the last several years on average. All right, we'll take a look at Willamette on slide 13. And, we actually saw a relatively similar pattern as Kaiser, with a little bit of an increase in 2017-18, followed by a drop. And again, a very significant drop due to COVID, down to $330, and an increase back up actually 63% on a per member per year basis to $433. But again, not quite to our pre-pandemic levels. And that's, I would say, consistent with a number of the groups that I've worked with, through the period. I think I misspoke there. I think the total in the total paid costs were not 63%. That was a jump in the member paid costs. So the total plan cost is a little bit smaller than that.
Brad,
And,
do you
Mhm.
think that 2021 there still is demand suppression included in that?
I personally think that's correct. I think that we had, some waves that still caused concern. I think also, though, that we probably are seeing some level of, as people get used to not going to the dentist again, there's probably some inertia to that as well. And I think we may have seen just a little bit of a long-term shift in utilization patterns. I think probably we'll need to work hard to correct that, certainly on the preventive side. We do not want to see that pattern continue.
Yeah, because I view it as three different potentials. One is that the capacity in the dentist's office decreased because they ended up having to do things that involved the COVID prevention activities that actually decrease their capacity. The second one is what you just described, is the decrease in overall demand. And then the third would be, losing things drop during the worst part of a surge. People would drop their visits, and basically that stuff would be pushed back, not necessarily go away. The first two potentially are there for the long term, and that those will be things for us to watch for.
Yeah, completely agree. Yep. But these are consistent
and we'll
findings
talk.
with other groups. Yeah.
We'll talk to each of the when each of the plans talk with us in the second half of the dental. That will be one of the questions that we'll ask is what do you think has happened with, definitely there was a return after the 1920 experience where utilization fell off the cliff in March, April. So
Yep.
but that will be something that we'll ask the plans to respond to also.
Yes, absolutely. Totally agree with that.
Thank you.
Should be interesting to watch it. Okay. So we can move to slide. Any other questions before we move off of the, kind of long-term per member per year cost view? Okay. Move to slide 14 here. All right. And so take a quick look at cost by service category. Certainly we have we all know we have our preventive, our basic, which is our standard fillings and things. And then we have our major restorative, which are our crowns and other items like that. Looking at by carrier, we see the distribution of cost remaining fairly constant for Delta. We had about 42% of our cost was devoted to preventive care, about 27 to basic care, 20%, 21% to restorative, and then right around the 9-10% to ortho. So very consistent year over year. And that's a pattern I think we'll notice for Delta, who in general, I think recovered from the pandemic quicker than in the prior plan year than either Kaiser or Willamette managed to do. You know, looking at Kaiser, not unexpectedly, we did see a increase in the amount of claims attributed to preventive. So that's good, going from 37 to 40. But we did also see that in basic, and a drop in restorative, and a drop in ortho. I think that reflects a little bit of certainly during the pandemic, if you really needed major work done, you probably went in and got that done. Or if you were in a course of orthodontic treatment, still retaining that. So those, I think that it's probably a reflection of an increase in preventive and basic services rather than a decrease in the other categories. So it's not something you know, a little bit different in Willamette. We did see a little bit of a drop in preventive and basic services, a little bit of a drop in major restorative, and that was driven by an increase, interesting increase in ortho costs, going from 14% of the total incurred costs up to 20%. So pretty big jump there. Any questions on kind of the cost by service category before we take a departure from cost and jump into utilization? All right, I think we can slip to slide 16, and we'll start taking a more of a utilization viewpoint here. You know, we can see that this kind of divides our utilization or our membership into folks who are not using services, folks who are what we would call low utilizers, but below $500 of cost, moderate, and then high utilizers at about $1,500 and above cost. You know, with Delta, I think, you know, we already kind of saw that we had a pretty high preventive visits or service utilization at about 70%. That's just a hair bit higher than the previous year, but still very good. And that really is implying that only 30% of our folks are not receiving a service, which is really nice. On Kaiser, that number goes up to about 45%, which is an improvement over the prior year, though. So we have this year, we have 55% of folks that are getting some level of service through the plan, and that compares to 45%. So again, not too unexpected with the pandemic. And the similar story for Willamette at currently 53% of members receiving some level of services compared to 48% in the prior year. Not unexpectedly, if we look at distribution of cost, we certainly don't have any cost for folks that are non-users. But we vary from about, you know, from a high utilizer perspective, no surprise, they're driving most of the costs, and that varies from about 40% in the Delta and Willamette up to a little over 50% with the Kaiser population. Any questions on that? Okay, slide 17 just has a quick refresher on what's included in preventive, basic, and restorative. If we have questions on that, we can kind of flip back to it, but for now we can move on to slide 18, where we have some data on our preventive services. So here we're looking at utilization of preventive services on a per thousand basis. We like to break out the Delta plans into the incentive plans and non-incentive plans. And of course, in those couple of incentive plans, you know, the more often you go in on a yearly basis to receive services, the higher your coinsurance level goes. And so we can go, you know, ranges from starting at 70% coinsurance. And if you receive proper care and do the right things over the course of the years, you can get that up to 100% and continue on in that as long as you're receiving your appropriate care. So not surprisingly, we see the highest level of services per thousand with the incentive program. That dropped just a little bit from the prior to the current year. Interesting. And then on the non-incentive plans, we still see very strong utilization with, again, a very slight drop from the prior to the current year, both above benchmark or book of business levels. For Kaiser, we see a really large increase. Of course, that purple bar for Kaiser was during the pandemic suppression, and we just see a massive kind of a catch up and return to pre-pandemic levels at about 33.66. So we're looking at like a 50% increase already over there above book of business, and also saw a good increase in Willamette. Not as big as Kaiser, but still pretty significant. Any questions on kind of that preventive services? Not, we can move on to the next one, which is our basic.
I was just going to say I'm encouraged to see that rebound, and obviously Delta Dental was stable through the process, but the rebound that we've seen both with Kaiser Permanente and Willamette Dental is very encouraging.
Yeah, and I think, you know, just real quick comment, you know, I think the service models of Kaiser and Willamette are very different, of course, than Delta. I think a lot of these independent dentists have much more, you know, much more motivation to get their membership back into to get them back into the office, get them back into their cleanings, get them, you know, back into their plan of you know, necessary care for basic and restorative. And I do think that's probably why we did not see as big of a drop. So we're, you know, still seeing more appropriate care probably on the dental side, driven probably by the payment models and things that are there.
Yeah.
All right. So looking at basic services, we did see, unlike preventive, we did see a pretty good drop for the Delta Dental plans. That was both on the incentive and non-incentive plans. And we saw an increase in both as well, you know, in the subsequent year, in this current year, as we return to services. Didn't have that really large claim suppression back in, you know, March and April of 2020. Similar story for Kaiser, saw a very good recovery on basic services, and as, again, not quite as large, but a good recovery from Willamette as well. So kind of an interesting year to go look and do a year-over-year comparison, because these are much larger changes than we would normally expect. So, but understandable given the significant pandemic suppression that we had in the prior year. Any questions on kind of the basic level of services? Not, we can move on to slide 20. This is our major, which is our crowns and so on and so forth. You know, again here, very similar to basic, all of our plans saw some level of increase, although not as large as basic. We did see movements both in the incentive and non-incentive program. And Kaiser, you know, again, as we saw kind of in that distribution, we saw an increase, but not as big of an increase as we did in the preventive and the basic. Same story for Willamette, and you know, I believe that's because when folks really need those major services, they often had to go in and get them during the pandemic. Those tend to be less optional when you need a crown or you're in a lot of pain. All right, any questions on that? All right, so slide 21 we can move to. So we'll take a deeper look into you know, how members are using their benefits, who's hitting the annual plan maximum. We do like to take a look at this by plan. Recall, as mentioned earlier, Willamette does not have a plan maximum, so it will not be included in here. And the Kaiser plan maximum, as we see here, is substantially higher at $4,000. So we have a much lower chance of folks hitting that. Still, we did see an increase in the number of folks hitting their plan maximums from the 1920 to the 2021 plan year. And that, of course, is because folks were not receiving as much care during the prior period. For the Delta plans, we did see some increases, most significantly actually in the EPO plan. We went down from about 2.5% of the folks that were hitting that annual max last year to 3.7. Kaiser doubled from 0.3% to 0.6%, but again, that's just a very small portion of that population. And in total, we saw an increase from 4.6 to about 5.2, which is just a little bit over 500 members hitting that maximum. So overall, some level of change, not concerning given, I think, more of the prior year experience than the current. And I think, Tom, to your point earlier, as we keep looking forward to the 2022 plan year, it'll be interesting to see how recovery continues and if we start seeing that number stabilize a little bit more. All right. So digging down into the incentive plans, we also like to monitor how folks are doing from an incentive level, remembering plans 1 and 5 can move from a 70% to 100% coinsurance if they receive, the dental care during the year and get their preventive visits, so on and so forth. And interestingly, we are seeing a growth of folks in the 100% category. That often is a little more stable, but, Delta did, kind of allow folks to continue in their current tier level if they did not receive a preventive visit. And so kind of allowing them to go up in tier, but not having them backslide if they didn't receive their preventive visit. So we ended up moving from, in total, in that 100% category in plan 1 from 47 to 53, and in plan 5 had a significant increase from 36% to 49%. All right, so there's no questions. We can move to slide 24 and just take a really nice deep dive into, preventive visits. There's quite a bit of information here. Some of this we saw in the executive summary, in general, members, on the incentive dental plans are more likely to have 2 or more cleanings. So we kind of saw that looking at about 37% in there. And that's just a little bit of an increase over the prior year, and kind of looking, across at the other carriers. We do have a fairly significant of members that do not have a cleaning in the last, 12 months or in the prior versus the current. And then we just have a repeat of the chart from a 12, 18, and 24 month view too. And just as a refresher, that 12, 18, 24 month view, that sort of says, folks may not be getting them every 12 months, but let's check and see if maybe they missed it or had to reschedule. Are they in 13 or 14 months? Or are people at least going in and seeing a dentist and getting a cleaning once every 2 years? That's kind of what this picture helps us to kind of look at and see how that utilization is changing over time. Any questions on that?
I have
Okay.
sort of a question.
Uh-huh.
So I'm looking at all of these and now looking, we're down to preventative, and I'm wondering, do we have the ability to do this data by geographic mapping and maybe by county to see, access and cost and all that kind of stuff, but by geographic mapping?
I think that is, so I'll tell you, Mark can jump in as well, but we do receive this data directly from the carriers. This is not data warehouse driven. So from, our perspective,
From the carriers, yeah, the data as we receive it right now does not come in that form. It's possible that they could. We do have the ability to pull similar information out of the data warehouse, and we can pull that by zip code and take a look at it on a geographic basis. And so that is something that either the carriers, could do. We could check with them, or we could take a look at the data and pull it directly from the data warehouse, and could do it with that regard.
And Bill, are you thinking kind of, hey, how is this differing between Eastern and Western? And those kind of things.
Well, yeah, and utilization by how far it is to go to a dentist, right?
Yeah, absolutely.
Other factors, just going one level deeper in the demographics to kind of understand this as opposed to a large group. That when we looked at the 5% cost about 10, 15 slides ago, 5% of the users are 40% of the cost. What are the locations? Where are those high costs located? Kind of a thing. Is this the best way to optimize these plans based on geographic and access, or access utilization based on geographic? Anyhow, just trying to look at one level deeper here.
Yeah, I think that's certainly from an equity perspective, I think that's a great lens to look at.
I would chime in, and I agree with Bill. I don't think we need to look at it that way every year, but certainly periodically we need to audit that.
I know that in our presentation, Delta Dental is going to be showing some differentiation by race and ethnicity. So we'll have a little bit more of that conversation, not from a geographic perspective, but from a race and ethnicity standpoint. But both are important, and great suggestion, Bill and Jeff, the idea of including it into some type of a review, maybe not annual, but every so often will be important. But that trying to find the populations who are at greatest risk is important. In fact, I think, again, I reviewed it yesterday. Delta Dental will show the difference between Western Oregon and I think Eastern Oregon in terms of utilization of some of their services. So we'll get into that conversation in our second hour.
Yep. Very good. All right. Great question. Thanks, Bill. Very good one.
Oh, my only question was how, I'm looking at the Delta, how could it looked like the numbers decreased in 24 months. I don't know how you could decrease in 24 months if you're higher in 18 months than 24. I don't know how that happens.
I think just looking at the different time periods in there.
I mean, it just, if it was more inclusive, you added more time, weren't losing anyone. So
yeah, you're seeing them decrease.
I'm just I'm a data geek sometimes, and it's like as you add time,
I'm seeing it go from 64 to 65.
Well, I'm looking at the two Delta ones, where it's higher. It's higher at 18 months than 24 months.
Oh, the 66 versus the 65. I see what you're saying. Yeah. Yep.
I don't think that's mathematically possible.
And it may have, and we could definitely follow up, but it may have something to do with the population, change in population and who is there. Some people that were there in the 18-month time period are not being counted in the 24-month time period because they're no longer there.
Yeah, that probably explains it. Yeah, a change in population probably explains it. Yeah. Okay.
Yeah. Very great observation. I think the key with the Delta is that folks are really getting in on average about every 12 months, and they're being very consistent in their service utilization. So very good point on that one. Okay. Go take a quick look at this for we take a look at this for preventive service utilization for kind of children or minors, members who are under 19. We want to take a look at who is using at least one preventive service in the last year, and looking at over the past 3 years, we can see that Delta was doing very well in the 18-19 kind of pre-pandemic plan year at 73%, and had a drop, but not a huge one, to 67%, and has since recovered to 69%. So very good utilization. Kaiser dropped from 56 to 40%, very consistent with their broader COVID impact, and then has since recovered to 56%. So back to pre-pandemic levels for kind of minors or children under 19. And Willamette dropped also from 57 down to 43 and is back up, but to 52%. So on the road to recovery, but not quite back there all the way. And looking at kind of on a 12, 18, 24 month, we do see some, some variation in here, a little bit more than we did for the population as a whole. So we are seeing a little larger percentage of these, kind of under 19 members who are receiving services in 18 or 24 months, which implies that there's a larger portion of this population that's not receiving one every, 12 months, so to speak.
I'm still on the slide I'm seeing still is 24. It didn't show. Did this slide get advanced?
Oh,
There it is.
It doesn't
It's
look like it
advanced
did.
now. Yeah.
Oh,
Okay,
perfect.
good.
Okay.
Thank
Sorry,
you.
I'm reading my own copy.
Yeah.
All right. Very good. Okay.
And Brad, you've got 13 more minutes.
All right. We'll move relatively quickly through this. I think we can see a similar story on page 26 for adult visits. Very similar story to the child. And then we can move on to slide 27, and we'll take a very quick look at sealants. We know that we've struggled to reach the statewide average in the past. This is no exception in the current and the prior periods. We did see Delta, having very consistent performance on sealants in the prior and current periods, and Willamette and Kaiser both dropping, but both recovering significantly as well, and outperforming Delta on the sealants for dependent children age 6 to 9. I will say it's a very similar story for children age 10 to 14 on slide 28. So we don't need to spend a lot of time on that. Any questions on sealants before we move on?
The good news about sealants is that I think we have a new measure that will look at use of sealants over time and actually show the percentage of kids who have been appropriately sealed as compared to just the number that are getting done at one particular year. So when you talk about an example, when you talked about how Kaiser and Willamette Dental were above Delta Dental, actually what you should probably be doing is taking the 2 years and adding them together and dividing by 2. Or just to add them, because the deficit is people don't get them every year. That's all. So yeah,
got it.
Continue on.
Okay, perfect. All right, so we can move to slide 30 and take a quick look at orthodontic cost. This is our last section in the report, and we can see that for orthodontia, we did have an increase in a kind of an allowed amount per member per year for all carriers. Delta had the smallest increase. We increased from $54 to $59, or about 7 to 8%. We did see Kaiser having a more significant increase at 15%. Recall that Kaiser costs represent their capitation arrangement and not on a kind of a paid claim basis. And Willamette, as we saw earlier, had a very significant increase in orthodontic costs from $47 per member per year to $86. So quite a large increase there. Any questions on that? So we can look at from a service perspective. This sort of gives us an indication of, what is driving that cost. Is it utilization of benefits, or is it the cost of those benefits? We can see that for Delta, a good portion of their
slide 31.
Thank you. Thank you, Mark. On slide 31, the services per thousand increasing at about 6%. So representing a lot of that per member increase. We did see the Kaiser utilization increase quite a lot at almost 30%. Again, those costs are on a capitated basis, not on a per service basis. And Willamette's utilization increased just about 50%, so driving a fair portion, but not all of that per member per year cost increase we saw on the prior slide. Any questions on that?
I'm just amazed by the order of magnitude difference in Delta Dental's utilization, services per 1,000 versus Willamette Dental and Kaiser Permanente. And obviously it has to do with what's covered and what's not, and
Yes.
on the plans. But what a huge driver
Of cost. Yeah.
Yeah.
Absolutely. Yeah, I completely agree.
So if you have kids who need orthodontia, you're pretty heavily driven or pushed towards KP and Willamette Dental.
Yeah.
Yeah. Okay.
Very true. Much more likely.
Yeah.
Unless your kid plays ice hockey, then you're going to go for some.
Then he needs the major restorative. Yeah. Got that.
All right. So slide 32, we can move on here and we'll look a little bit at prevalence of orthodontia use in the population, and this will be consistent with what we were just talking about. Certainly, we saw that Delta Plan 1 and 5 are the only plans that cover orthodontia, in the EPO. On the Delta side, currently, we have about 2.6% of membership using the plan or using orthodontia benefits in Plan 1. And that goes up a little bit at Plan 5. And in fact, we did see a little bit of increase in prevalence from the prior to the current year from 3.2 to 3.4%. And we did see a larger increase on the EPO plan, moving from 1.4 to 2%. Again, these are not huge numbers because the enrollment is not huge. So talking about like 120 to 175 people or members. Kaiser was had a little bit of an increase, moving from 4.4 to 5.2% of members, and Willamette also had an increase of 4.4%, or also had an increase moving from 4.4 to 5.3%, representing a little bit over 1,000 members. All right, Tom and Matt, take
a curiosity question.
Mm-hmm.
In the last 5 years, there's a lot of new orthodontics technology. Like, we don't have the big screws like my kid had. Does that increase, decrease? What is that doing to cost as we're going into much different technology in orthodontia?
I have to tell you, Bill, from my perspective, I am not an expert in that. I would love to hear the carrier perspectives on that. I think that would be a really interesting question to ask the carriers.
We'll move that to maybe a fall topic where we can dive a little deeper into orthodontia and give our plans time to talk about what they're seeing in regards to the different technologies. I think part of the technologies that you're talking about, Bill, are expanding who gets it. I mean, you just described your kid getting orthodontia. The classic was, the 10 to 16-year-old with getting orthodontia. And I think some of the expanding technologies are adults getting teeth straightened and things like that. So we can explore that and see what's happening.
Yeah, it's interesting to see how new technology is driving our costs one way or the other, right?
Yep. Agreed. Yep. Okay. Brad, is that, I think you just said that's the presentation?
That's correct.
A wrap? Okay.
Yep.
Thank you very much. Any further questions before we move on to the next topic? Okay. So what we have is now 50 minutes. We're going to be going through an update on dental utilization for each of our three carriers. And I see that Kaiser Permanente is first up. Dr. Pilstrom and Mr. Abraham are going to be bringing that to us. And so Dan and Nick, you're on.
Hi, everybody. Good to see you.
Good morning.
Nick
Can
Abraham.
you hear us okay?
Yes.
Great.
Excellent. So I'm Nick Abraham, the dental manager for Kaiser Permanente in the Northwest. And then Dr. Dan Pilstrom will be going through the utilization. You can go to the next slide. I'm going to go through a few things on kind of capabilities that we've developed. You've seen these before. I'll just touch base on two of them. And these are really aimed at making it easier and more convenient for the member to get in access to care. And so the one I'll highlight is dental only access on kp.org. That's a big deal for OEB because about almost 1,700 members were dental only, meaning they had a medical plan that was not with Kaiser Permanente. Previously, you needed to have a medical plan to be able to join kp.org, and that would give you access to our KP app online. You could view and cancel your appointments, look at your after visit summary, receive non-urgent dental advice, pay their bills, and so on. So there's a lot of services now they can do online that came on January. And then the big one, we are excited to say online dental appointing. That's correct. Online, finally, for us, is happening beginning April. 17 of our 21 offices right now are offering online appointments. But let me explain what that means. And that's for routine hygiene, should help with preventive services. This is through a reaching out email text system. So our system knows when you need a dental appointment, and it will trigger a ticket that will come out to you to go ahead and schedule online, just like you would for a primary care visit. Same virtual experience. So it's not just on a voluntary basis, but it's based on if you need an appointment. So that's how that works. You can go to the next slide. So some of the things that we're doing, you know about them, but just a recap of really focusing on prevention. We need to increase that. It was seen in prior reports that especially the unseen member numbers. So as you know, May of September, we did an outreach. It actually was almost a 34% increase in action taken, improved the benefit. And then kind of future going, our technology and online appointments, that's really going to be our catalyst to help continue this synergy. So we hope to see, the goal is that those services will continue to rise. We want to see that increase. And really, it's more of a surgical, tactical, looking at our oral health risk assessment, which is done on every OEB member. When they come into the dental office, they receive an oral health risk assessment and an after visit summary that helps explain what is your oral health, where are you at, and what is your treatment plan. And so for those that are healthy, we're not going to give them 2 cleanings a year just because they have the benefit. We'll recommend maybe 1 cleaning a year. So that kind of explains our numbers a little bit around prevention and diagnostic. Next slide. And I think that the big topic is, looking at where we've come from COVID. Make sure it's on the next, there you go. Our staffing. So a lot of work is being done for us, especially in the dental assistant area. This is a place that's a national shortage. It's something that we've had for a long time now. COVID actually exacerbated the issue. When it's easier, instead of being in the mouth, to actually go to an on-time, a role that maybe is outside of dental. So we are working and focusing on increasing dental assistants. So overall, what we're looking at is to support the community. Kaiser Permanente is working with Portland Community College to boost their dental assisting program. So that means we're going to cover the tuition. We're looking at about 40 students that will go through that program through 2022 and 2023. They will have job placement at Kaiser Permanente when they finish that program. And that should really help us overall to at least get a pipeline, because it's a struggle, not only nationally, but locally in that area. In terms of hygiene staffing, we're pretty on par, just barely below budget. From dental assistants, we're at about 90% staffing. So we do have room to grow in our staffing there. And then overall for dentists, we're managing that pretty well. So we've had high retention in the dental group. Next slide, and I'll hand it over to Dr. Dan Pilstrom.
Yeah, thanks, Nick. And I think that those last few comments about workforce really get to a lot of what Tom, you and Brad were discussing around what are the drivers of utilization, what have been the drivers of utilization. And this graph really tells a big story, I think. You know, compared to 2019, we're down, and that's due to we're frankly not really running as many multi-chair schedules with as much visit density as we have in the past due to lower numbers of dental assistants. So that work around developing a dental assistant training program for Kaiser Permanente, as well as partnering with community members to drive more increases in dental assistance in the community and for Kaiser Permanente is huge. And I'm sure the other carriers will also echo that sentiment. I think the other story on this, with the utilization being down in January, we were hopeful that things would return quicker, but you know, that was Omicron. That was like the beginning of the year. That was the variant, and we did see a big impact on utilization, I think, from that. I always enjoy the Willis Towers Watson presentations because it's just good to see how we show up and where the opportunities are, and you just kind of see those trends over time. So, and we certainly see it in our data, which I'm going to go through here. Go ahead and hit the
Dan.
Yeah,
Dan, what I didn't do, and I apologize, is to identify time frames that each of the plans have.
yes, thank you.
Each of the plans get 20 minutes. So you've got another, I think, 12 minutes.
Got it.
Yeah.
Will do, Tom.
Thank you.
Hit the next slide, please. So this is diagnostic and preventative services. Nick previously mentioned, and Brad as well, as we've reduced the number of the office visit fee for that. We still continue to see a bit of suppression in utilization, and I think of diagnostic and preventative services. I think there's a couple things going on. We're trying to understand it ourselves as well. I think there is a decrease in demand, and I think that idea that Brad hit on, which is this inertia of trying to get over patients coming in more, is still an issue, as well as staffing. You know, what we're starting to do in our program is also consider fluoride varnish and preventative services provided by physicians. Now, not all OEB members have Kaiser Medical. This data does not take that into account, but that is, it really provides the whole picture of what types of dental services are being given to those patients when you combine medical and dental. And that's data that I hope to share with this group at some point in the future. Next slide. You know, type 2 dental services like dental fillings, we actually are pretty much back to pre-pandemic 2019 levels in terms of utilization per thousand, as well as our periodontal services. You know, there's two types of cleanings. There's a preventative cleaning, which is not a therapeutic cleaning treating disease, it's prevention. And then there's a therapeutic cleaning for patients with gum disease. Those types of cleanings, which we do a lot of, fall under the periodontic cleanings. And these types of appointments for patients can be pre-booked for them, so that, because the goal for those patients is to get them as close as we can for their recall. And for patients that are due and on a 3 or 4 month recall, they can pre-book ahead of time. So that's really helped us, I think, get back to some of our 2019 levels in terms of utilization. Next slide. Endodontic and oral surgery. These numbers have stayed pretty consistent after we went through 2020, in part, I think, due to some of the themes that Brad hit on, which are these are just essential dental services that patients do not tend to delay, because they're medically necessary in a lot of cases due to pain and things. So we have good utilization back to 2019 levels. Next slide. Denture, crown, and partial services. Here too, crown's services, the Willis Towers Watson data is always interesting. Kaiser, I always look at because our high and moderate utilization tends to be the highest in terms of those dollar amounts among the three carriers. With crown services, we're down a little bit from 2019. I think, we're ahead with fillings. I'm not sure if we're seeing a delay or pent-up demand where we're going to see that slowly rise. We're still trying to understand why it's not back completely. These services tend to require longer appointment times and things like that. So it could be a capacity issue. Although demand on the demand side and with our access being good, I do think demand suppression is also an issue. Another kind of macroeconomic thing going on is inflation. I don't know what that's going to do with dental utilization overall, but that's just another kind of thing to think about as we look at utilization numbers. And partial denture services seem to be back to 2019 levels. Next slide. And that's it. There's a couple appendix slides. I'll go through really quick, unless there's questions. Are there questions? Okay, let's move on. This was the outreach that we did in 2021, very successful. And we'll look at this, as Nick said, as needed periodically to ensure that we're getting good utilization for OEB members. Next slide. And here's our risk assessment tool that we use, which gives patients information about how they can keep themselves healthy and is tailored to them based on their risk factors around tooth decay and gum disease, and makes recommendations for once or twice a year cleanings, as well as periodontal cleanings and other things that patients can focus on to reduce their risk of developing the two major diseases that we treat in dentistry, tooth decay and gum disease. And with that, I think, yes.
Yeah, Dan, what's been the response to the after visit summary for these two issues? I mean, this looks like it could be pretty powerful for people.
We've been doing this for a long time. It's after visit summaries. I don't know how effective they are. They get printed, they get shown patients. They're on kp.org. It's supportive of what we're telling them chairside. I like to make it more visible to members, and if they're using the app, I think it will become more visible. So I think there's always opportunities with patient literature, and I think as long as a lot of patients need multiple sort of inputs. You talk to them, you got to show them a graph, you got to give them literature. It's online. So to us, it's just a tool that helps us and connect with the patient on what their risk is and what they can do in the future to reduce their risk.
Yeah. What you may want to do is get green, yellow, and red dots, and if they're high risk, they get a red dot in the middle of their forehead or something.
Oh, I hadn't thought of that.
Yeah.
I don't know if that would be accepted by patients very well.
Probably not. Probably not. Always just trying to help.
Yeah. Thanks, Tom.
Yeah. Okay.
And with that, I think I will pass the baton. Thank you, everyone.
Yeah. Thank you. So conclusion, it looks like significant rebounding in your program, and the issue still around suppression. The other part of suppression that I think happened is with the Omicron, both Delta and Omicron, that people were maybe fearful to going to the dentist. The other part was a lot of people were sick and couldn't go. And then the other part that I think everyone has seen is staff members getting Omicron and being out of the ability to see patients. So, we haven't talked about that yet, but I know that was a major component this last winter. trying to
Definitely.
maintain staffing was difficult for everyone. Okay, so we're now moving on to Delta Dental, and Dr. Barcello is here to talk to us about your 3-year experience. So Terry, are you there?
I am here.
Great.
Thank you. And we'll continue that theme of kind of what's been happening through the pandemic. But for today, I'm just changing things up a little bit. I'm focusing really in 2 different areas, which is the rate of visits, which for me is trying to represent or get access to care, and then doing a deeper dive on just preventive services for adults and kids, looking deeper into how the different populations are being served. For each of those categories, I'm going to show the overall performance, and then we'll break it down, as you referenced earlier, by race, ethnicity, and then by geographical location, but not to the degree that was brought up earlier. I think it was Bill who had mentioned it on a by county basis, and I think that's a great takeaway. We'll follow up on that for future opportunities. We really just broke it out into kind of chunks of the state to see if there are differences in performance. And then also to keep things, the charts a little bit cleaner, and then just recognizing that 2020 was a singularly odd year. The data comparisons that we ran uses 2019 as a baseline. We show 2021 as sort of the recovery, and then we have the first 3 months performance of 2022. And for all of the reasons actually that, Tom, you just outlined, I think the first 3 months of 2022, I hope, are not an indication of how the entire year will play out, but it's just good to get a sense of how things are running. And let's, with that, go ahead and go to the next slide. So here we're looking at the unique visit count per 1,000 members over time, and over time that's a week by week comparison. And looking at 2021 versus 2019, it ended at 94%. So we're showing a really strong recovery, and the theme throughout is pretty much very strong recovery in 2021. And in a couple cases actually surpassing performance, but we'll get to those towards the end, but not yet a full representation of what pre-pandemic life was like. And then for the first 3 months, 2022 is running at 91% of the prior year, but still trending, well behind 2019 at 86%. And we'll go ahead and go to the next slide where we start to get into the breakout. And I'm going to apologize right now. My presentation today is very numbers driven. So maybe take an extra sip of coffee and bear with me as we get through all of this. So with the chart on top, you can see that the unique visit rate for all races has not yet matched that of 2019. But I will say the chart is a little bit deceiving. So for example, the visual spread, despite the visual spread that you can see, the visits for BIPOC members for 2022 is trending at 93% of 2019. So it's a little better than it looks there. And the rate is also 93% for white members. And for members whose race is unknown, it's at 86%. The chart also shows white members have more visits in each of the years represented than our BIPOC members and members whose race is unknown. However, again, it's a little bit deceiving because for 2022, BIPOC member visits are 96% that of white members. Then moving to the lower chart, this demonstrates visits by reported ethnicity. So non-Hispanic member visit rate, 2022 to 2019 comparison is 82%. And for Hispanic members, it's 88%. The 2022 utilization appears to show Hispanic and non-Hispanic members are visiting the dentist at the same rate. And I apologize because I didn't catch that error before our slides were submitted, but that's actually incorrect. Hispanic member visits are trending below non-Hispanic members by 13%. Go ahead and go to the next slide. And here we begin to see things by geography. So we use the 4 different breakouts: Central and Eastern Oregon, out-of-state members, but in that category, we did not include Clark County members. Clark County is actually included in the urban category, which also includes Multnomah, Clackamas, Washington, Lane, and Marion counties. And Western Oregon includes our coastal counties, Jackson, Josephine, Douglas, Lynn, Benton, Polk, Yamhill, and Columbia counties. So in 2022, the first 3 months compared to 2019, Central and Eastern Oregon is performing at 88%, out of state at 84%, and then Western and urban are at 94 and 93% respectively. But you can see by geography, there are some differences where members are accessing dental care at a higher rate than in the more rural areas or more typically rural areas. Go ahead and go to the next.
So is out of state mostly Idaho?
You know, I didn't get the breakdown of all states, but with you have to remember, MOAB members may have children that are in college all over the U.S. So I can't say for sure, but that's something that we can look into to see kind of the spread of where those out-of-state claims are coming in at.
Yeah. I'm just thinking that Idaho was pretty slammed in 2021 with Delta and pretty slammed with Omicron in the winter. So that might be part of it.
That's a really interesting point, Tom, and I will follow up and see if if we can prove that to be the case.
Yeah, the other part, I'm just thinking of where, and the other part would be kind of Tri-City. You've already included the major hub with Clark County. Then the next hub would be out of state, would be people on Ontario on the eastern border of Idaho, and then the third one would be Tri-Cities for people in the Umatilla, Hermiston area.
Yep, exactly.
Okay. All right. Thank you.
Okay. Yeah. We'll move on then to looking at child preventive services. So we're defining a child here as 18 and under. And the utilization for these members, we're seeing a really strong return to pre-pandemic utilization. So 2021 ended at over 95% of 2019. And 2020 is off to a great start as well. And just to level set, for preventive services, we're talking about cleanings, fluorides, sealants, those types of services, not including diagnostic. Go ahead and go to the next slide. Great, thank you. So breaking out child preventive services by race, and I think some really good numbers in front of you. So for at the very top, white members looking at 2019 compared to the first 3 months of 2022 is at 93%. And for 2021 performance, it was 95%. And for BIPOC members, those numbers were 92% at the start of 2022 and 96% comparing 21 to 19. And then comparing BIPOC member services versus white, they're performing there's about an 8-point differential between their rate of services. Moving down to the ethnicity, comparing 2019 to 2021, Hispanic members utilization is at 96%. And for the first 3 months of 2022, it's at 85%. Again, reflecting, I think, the Omicron impact possibly. For non-Hispanic members, in 2021, their utilization was 96% again, and 93% in the first 3 months of 2022. And there's looking at Hispanic utilization versus non-Hispanic utilization for children. For 2021, there's about a 7-point differential in the way they utilize services. Go ahead and go to the next slide. And here we have it broken out by geography. By each geography, everybody's 2021 performance is in the mid to upper 90s of 2019. And for 2022, we're off to a little bit slower start. But in Western Oregon, we have the exception where 2022 appears to be running a little bit ahead of the other years. And I just don't put a lot, like for either way, overperforming, underperforming for the first 3 months of 2022. I don't put a lot of impact on that yet. It's just too early to tell what that really means and how the year will play out. Go ahead and go to the next slide. And our final breakout will be looking at adult preventive services. So again, in 2021, we have a strong recovery. It ended at, utilization ended at 95% of 2019. And for the first 3 months, we're at 80% of 2019. Go ahead and go to the next slide. Breaking it out again by race and ethnicity. There's some interesting differences with this chart than the others. For looking at 2019 comparison to 2022, white members are performing at about 3% above that of 19. They ended the year of 2021 at 96%. For our BIPOC members, the 2022 year is off to a 5% higher performance than 2019. And I did double check these because it did stand, all these categories kind of stood out to me, but they did match the data that was sent over. And 2021 to 2019 performance for our BIPOC members was just about 100%. The difference, though, comes in the comparison of looking at utilization of BIPOC members versus that of white members, and there's about a 17-point differential there. The lower chart breaking out ethnicity, our Hispanic members in 2021 ended at about 1% higher than that of 2019 utilization. And for the first 3 months of this year, they're at 99% of 2019 utilization. For non-Hispanic members, 2021, 99%, and for the first 3 months, we're at 103%. But there is, again, a disparity between Hispanic utilization and non-Hispanic member utilization of about 18% in 2019, 84% in 2021, and 78% in 2022. And go ahead and go to the next slide. And finally, we break it out by geography. And again, pretty much the same, performing around 90, in the mid 90s of 2019, with the exception of the urban areas. In 2021, we ended 2% higher than in 19. And for the first 3 months of 2022, it's 7% over that of 2019. And then Western Oregon, similarly, the subsequent years have been performing a little higher. But I do, again, I just don't put a lot of weight into that 2022 performance. I do want to add just some predictive comments, if I can, about prevention and preventive services, especially on the heels of the Willis Towers Watson presentation. And historically, the Delta plans have performed really, really well, but for a lot of the reasons we've talked about. But very significantly, the labor issues, specifically as it relates to hygiene capacity, hygiene chair capacity. I'm wondering how the Delta plans will continue to perform over the next few years, because we are hearing pervasively that dentists are having a very hard time recruiting and hiring hygienists, and they're some dentists are reporting that their available chair time for hygiene services are at about 50% of what they were even a year ago. There are a number of things that we're all working on. I think all the plans are engaged in a lot of different things around workforce and encouraging a new pipeline of workforce, encouraging a return to the workforce for those who had left it during the pandemic. But I really believe, or I fear, that some of those strategies are going to take time. These are not short-term solutions. It will take time to play out. And I don't tend to be a sky is falling kind of person, but I did want to at least give you guys a heads up that I think there may be, in subsequent years from now, a bit of a change in the performance of preventive utilization, at least within the Delta plans. But time will tell. Hopefully there'll be a turnaround. And that concludes my presentation. I'd be happy to take any questions.
Any questions from the committee? Yeah.
Did that last sentence translate into the sky might be falling?
It's just a forecast, right? I mean, they forecast sometimes sunny and it's a bit rainy. I hope I'm wrong. I hope that it's not as dire as what I'm hearing. I think part of why there's the urgency in my 25 4 years of post-graduation, I don't recall ever a time when dentists have been in this situation with not being able to afford to hire, not being able to have, there are no candidates to hire. And I think I'm really picking up on their panic around that. And it really does, from their sense, it does feel like a bit of a panic because nobody knows exactly when this will turn around.
Two different things. One, this may drive, the sense that I get is that in the dental office, private dental office, it's just the routine is every 2 years for cleaning. And it may drive the risk assessment differentiation of if you are in that low risk, it's every year. And you know, so that you're able to get the people who are in the moderate and higher risk in more frequently. It'll be just interesting to see how that plays out. The other question, I applaud Delta Dental for your breakdown of utilization and services by geographic differentiation and by race and ethnicity. We'll need to be seeing that from all of the dental plans. And so, and obviously when you have you know, the most recent slide you showed had the differentiation of Hispanic, non-Hispanic, and BIPOC versus white, and they were in the 17 and 18% difference. What do we do about it?
Yep.
You know? So that's the conversation. Obviously, I would like all the plans to be starting to think about that and talk about it. We may need a forum, because my guess is that what Delta Dental needs to do is pretty similar to what Kaiser Permanente and Willamette Dental Group have to do. But you don't even start asking the question until you see the differentiation. And this other differentiation is in that same, you know, not quite as pronounced, you know, the Central and Eastern Oregon numbers that we're just looking, you know, at right now. There's a 10, 15% differentiation. Not surprising from a standpoint of availability of services, but what do we do about it? That needs to be the conversation. So, but we don't even start asking the question until we see these numbers. So thank you so much for your group putting this together. Very, very helpful, Terry.
Thank you.
Any other questions or comments as we get to this? I actually, and Dan, I see you're still around, and Terry, you're on. And as we get to Willamette Dental Group, the Health Plan Quality Metrics Committee approved a new quality measure around sealants. And it allowed for, it basically was, you're able to look back years to be able to see whether or not a person, a child was appropriately sealed. Have you gotten that information yet on those new quality metrics?
I haven't seen it yet, so I can't yet comment. I apologize.
Okay. No, that's all right. Dan, have you seen it?
Yeah, I've seen it, and it kind of worried me, frankly, just because the data pulling could be tricky. But
Okay.
I don't think we've done have the analysts really pull stuff yet with it.
Okay, that's fine. So it just means for sometime this summer we'll get the three dental providers together and review what has been allowed, what the specifications and things like that are, and make sure that it's going to work for the three of you. And I say that, and we're now moving on to Willamette Dental Group, and Dr. Chambers and Ms. Nicholson Mark and Tiffany, you're on. And Mark, if you could comment on briefly on that new quality metric around sealants towards the end of your presentation would be very helpful.
Great. Good morning. Thanks so much for having us. My name is Tiffany Nicholson. I'm the Key Account and Client Service Supervisor that manages the OEB account. With me today is Dr. Mark Chambers, and he is our Director of Clinical Operations. And also on the call today is Darcy Engel, our Director of Sales. So this first slide here, just as a reminder, we are waiving that $20 office visit copay for all new patient appointments for OEB members that have never seen a Willamette dental provider. So we started this back in March of 2021. Throughout the remainder of that 2021 calendar year, we had 1,227 OEB members that had that office visit copay waived. For 2022, so starting January 1st through March 31st, to date, we've had 416 members receive that copay waiver. This will continue through the remainder of this plan year, as well as it was contracted into the renewal negotiations for the 2022 and 2023 plan year. Next slide. So overall appointment utilization, we are comparing calendar years 2019, 20, 21, and then 2022 contains data through the end of March. We are trending pretty close to 2021 to 2019, we're at 87% of pre-pandemic. No-shows, we are still having a much higher rate than we saw pre-pandemic. We recently released a new patient experience enhancement through our patient communication tool. So we currently provide recall messages for our patients via their preference of phone, email, or text. They get these reminders about 10 days before services are due. And then once they're scheduled, they get those reminders 3 days before as well as 1 day before. So starting just a couple weeks ago, back on May 16th, our patients are now able to cancel those appointments directly through those reminder messages based on their preferred communication method. So instead of having to call in to cancel that appointment, they can simply do it from their own preference via that text message. It brings them to a link and they can cancel it that way. So we're hopeful that these enhancements will reduce the number of no-shows, which we can use better clinical time and see more patients, as well as provide a more modern self-service experience. And now I'll hand it over to Dr. Chambers to dive into our utilization by category.
So on to our next slide, I think it's interesting. Tiffany talks about no-show rate. And as you can see on that previous slide that we had, it is trending up pretty significantly with, if we go at the continual rate or the rate we're going at now, we're going to surpass even no-show rates that we had in 2021 that were quite high. And obviously, when we look at utilization, when we look at providing the needed preventative procedures to our patients, we have to have them, or we need to find a way to get them in the door and get them receiving that treatment. When we're looking at utilization of basic services, you can see we're really back to those levels that we had pre-COVID. In fact, meeting and surpassing the months of February and March. When we talk about basic dental services, we're talking about those services that are kind of the bread and butter dentistry. They're our fillings. They are our diagnostic ER appointments. They're kind of our, not our preventative cleanings, but our scaling root planings and our more involved perio treatments. And those basic dental services were some of those that really dropped off during COVID. Tom talked about maybe some of the reasons we're having a decrease in utilization through all three plans. And I think there's really three functions of this. The first is, there is a patient hesitancy to come in because of COVID still from some people. I saw a family of 4 yesterday, and as I went in and I saw the mother of the 2 children and her husband, she mentioned to me how nervous they were to be back at the dental office. And her nervousness wasn't just because of COVID. Her main anxiety about being back at the dental office was that they hadn't been in a couple of years because of COVID, and they were really nervous of what they were going to be told. Did they have a lot of problems? And she said they had been putting off that dental appointment for quite some time for that reason. They were just anxious and nervous what they need to have done and taken care of. As clinicians, we have our outreach to our patients through our front desk or our care advocates. We have our recall reminders on those patients that we're really worried about. The docs are even reaching out, or our hygienists are reaching out to try to encourage those patients to come back. So that was one. They talked about staffing earlier. I applaud Kaiser and their efforts in working to kind of increase the dental assistant pipeline. I can tell you that is so important to provide, especially preventative care. A lot of those preventative procedures are being provided by dental assistants and hygienists, and if we don't have appropriate auxiliary staff, it affects our ability to do that. Over the last 6 months, to a year, we've done 3 different things to try to improve the staff picture. We're working with Concord College, our career college in Portland, working on internships and developing their dental assistant pipeline. We also are working with PCC, and we actually have full ride scholarships for 6 dental assistants we provide every year. And then we're also teaming up with PCC to provide internships and job placement. And then most recently that we just had developed 2 months ago is that we are working with Oregon Health Authority in the How-To grant, where it's promoting development of hygienists and dental assistants and job placement and growth. So we're going to continue to do that, and the success of dentistry in Oregon really will be on building up that the staffing situation again. On to our next slide. We look at preventative dental service utilization. You can see that we similar. See if we go to the next slide. Awesome, thank you. We are surpassing 2021, 20 and 21 years, but a little bit below our preventative service utilization for 2019. Part of that is staffing, part of that is patient hesitancy. As we go to the following slide, we dive into sealants, and Tom asked about sealants and sealant metrics, and similar to what was shared before, sealant metrics are so tricky because you do look at, okay, has the tooth been sealed previously? Has it had an occlusal restoration that makes that particular tooth not sealable? We also look at risk factors on patients, and there is great literature to support that sealants on moderate, high, and extreme risk patients are very cost effective. Sealants on low risk patients cost more than the economic benefit you get from it from a actuarial cost perspective. So looking at sealants and these new measures, there will be challenges with reporting for many groups, but I do applaud efforts to try to improve these sealant metrics so that we're getting a real true picture of the preventative services we're providing patients. On our next slide, it dives into kind of that risk assessment of delivering preventative care, particularly sealants to patients. And we've had a significant improvement in delivering preventative services through some changes we've made to our electronic dental record. And through these changes we've made to electronic dental record, in the moment, it sends out prompts and encourages the providers to do appropriate preventative care. And you can see we've been hovering right around 70% for sealants as patients come in the door. And this is a treatment that's delivered that day and or within a 30-day window. And obviously 70% is better from where we were, but our goal is to get much higher. I mean, ideally, we'd like to be up to the point where we're doing sealants 100% of the time on those patients that need and are going to benefit from that treatment. On our next slide, further talking about preventative services.
I have a quick question.
Yeah, Tom.
A quick question on sealants for the high, moderate, high, and extremely high risk. Were those for children? Is the denominator all the kids in that category, or is it just those who were seen for an appointment who are in that category?
Yeah, great question. So kids between the ages 6 and 15 that have molars, first or second molars that have not been sealed previously and or unrestored.
Okay.
And they are patients that have come into the clinic and we have seen them.
Got it. Yes. Got it. Okay. So it's so it doesn't capture the people who previously have been identified as high risk, but who just aren't being seen.
It does not. Now, those patients would show up on past months when they've come in, whether they came in 6 months prior or 8 months prior, they would show up in the statistics at that point.
But if they hadn't been seen in a year's time, they wouldn't be included.
They would show up on those past. So that's a month by month basis. So that means that, so if we're looking at March, 73% of our patients that came in March received appropriate sealants.
Got it. Okay. So so I can understand why you say, that should be higher. I mean, it's really good where you're at, but you have the potential for that getting higher.
And I mean, ideally, we want that 100%. Now, I can tell you, we offer it to patients, but sometimes patients say, "Oh, we can't stick around to get sealants done today."
Got it.
Or we don't want sealants, and then you try to explain to them why they should get sealants. And
got it. Yep. Okay, thank you.
So, fluoride looks really similar to, the basic services chart. And really, a lot of that kind of comes with, as they come in. On the following slide, you'll see that if a patient is moderate risk, which really our moderate risk patient is any patient that has risk factors. Let's say they have a high sugar diet, or maybe they're not the best brushers. And on the next slide, if you'll flip to that. Thank you. You can see that we've been trending, over the years from 2019 to present, real consistently between 99% of patients and 96% of patients that come in that have any sort of risk factor are receiving a fluoride varnish and a prescription for a prescription fluoride toothpaste to use at home. One thing that I think is noteworthy, Dr. John Featherstone out of UCSF, he was the dean of the dental school. He's probably the most prominent caryologist in the United States in terms of studying caries and what drives that caries process. He did a study, and it's been replicated by many other studies, showing that if a patient goes home, changes nothing else, and they're using a 5,000 part per million toothpaste, we'll get a 40% reduction in cavities. And that's just a phenomenal improvement. He also showed that if a patient concurrently was high risk or extreme risk for cavities, and they're using a prescription mouth rinse, chlorhexidine, 1 week out of the month, rinsing with it once a day for that 1 week, concurrently with the prescription fluoride, they received a 68% reduction in cavities. And so in terms of prevention, obviously we have prevention we deliver at home, but we also want prevention that the patient can continue to deliver, we have prevention we deliver at the office, but we also have prevention we want them to deliver at home to themselves. We found that currently within the organization, we have a 98% prescription recommendation for a prescription fluoride toothpaste for that group of patients. And we have a 98.2% prescription recommendation for patients using chlorhexidine at home for that patient group. And that continues to be a focus with our providers in providing preventative care. One other thing I just want to touch on before we open up for questions is that, higher no-show rate and patients just not following and returning for care. We've really made an increased focus on saying, hey, let's try to get patients treatment completed at the same time they come in for their cleaning appointment. And currently as an organization, we're at 42.8% of patients that come in for their cleaning. We also provide additional treatment at that same day, whether it's a filling or other preventative services. And with the idea that we really just we got to get them while they're in the chair and make sure that we're providing that appropriate and needed care. As we slide to the, or go to the last slide, just open it up for any questions to the group.
Any questions from the committee? I would be interested in hearing your thought about the explosion in orthodontic services.
Yeah, oh, that's a great question, Tom. You know, so a couple things, the statistics that Brad showed, and he showed percent of cost from 2020 to 2021, and you can see the huge jump in cost in ortho, and it showed, and this was a percentage of cost, right? And then it showed a decrease in cost of preventative care. I just want to point out that we actually had an increase in utilization of preventative care, but because the percentage jump in orthodontic care was so significant, it made it look like preventative went down, but really preventative went down, but just percent of cost.
Just a percent, yeah, I got it, yeah.
But it really comes down to 2020 and restrictions that were put by the state in terms of what was allowable treatment. And because of restrictions on non-essential care during that time, ortho took a big hit in 2020. As a result, we kind of had a backlog of patients that wanted ortho in 2020.
Got it.
That then came in 21 to have that treatment delivered. So I bet you over time, we probably see the ortho costs actually kind of drop a little bit and stabilize from our 2022 levels that we're seeing right now.
Okay, thank you. Ollie, you have a question?
Yeah, thank you, Tom. I was just wondering, you spoke about staff shortages and you know, some of the difficulties there. I just wanted to ask if you could comment regarding, say, a member has a toothache or some other problem. Are you able to see them? What does the duration, I guess, of scheduling appointments look like right now?
I love that. I was going to touch on that for emergency appointments, those patients take top priority for getting in. We, as an organization, we're shooting to get that patient in within 24 hours. You know, sometimes that falls on a Sunday and it gets bumped out a little bit more. But providers are, you know, they care about the patients. They want to get patients in for that. Although we really saw a hit to staff right after COVID, we've seen those numbers significantly improve over the last year and continue to improve, making it easier to see patients. We've done a couple things as an organization. We've increased compensation significantly for hygienists and dental assistants and front desk. We've increased 401k benefits, added some additional holiday pay. I mean, we've really gone above and beyond to be the, you know, employer of choice to be able to retain and keep our staff.
Great, thank you.
Okay. Any other questions or comments from the work group? Otherwise, I am going to thank you very much, Mark and Tiffany. And thank you to all of our plans and to Willis Towers Watson for our dental review. We will now have a 10-minute break. I have it at 10:50. We will reconvene at 11 o'clock. Rose, are you, can you unmute? Rose, can you hear me? I have it that it's 11 o'clock and we are restarting. The next presentation is an update on the additional cost tier program, and Willis Towers Watson is going to take us through that and give some recommendations about how we proceed with it. So Brad, you're there, and Mark,
I sure
know
am.
that you're on. So it's yours.
All right. Thank you very much. Well, this will be not the first time we've presented this information, although it will give a little brief overview for the folks that may not have been super familiar with it. We can move to slide 5, which kind of has a summary overview. Just as a refresher, the purpose of this report really is to review the impact of the alternative cost tier copay program on preference-sensitive procedures. These include things like hip and knee surgery and replacement, spine surgery and injection, high-cost imaging, various other surgeries. And the copays typically range from about $100 to $500. They were implemented in the 2010-2011 plan year, really intended to make people stop and think before utilizing these services if there were alternate treatment patterns they could do that maybe were less invasive or more efficient. They were implemented for the MOTA plans only and really did drive immediate reduction in the first year, then followed by what is seeming to be a lesser impact on trend in subsequent years. The study primarily compares OEB utilization and PMPM costs for these services to both book of business utilization and PMPM, as well as Kaiser utilization over the same time period, noting that Kaiser did not implement a copay, alternative cost tier type program like that. In general, we did see a sustained drop in utilization, I would say, with longer trend terms incrementally lower than the MOTA book of business. Kind of looking through these at a very high level or broad characterization, I would say the Kaiser utilization is generally lower for these procedures in magnitude, although we do occasionally see categories that have had higher utilization trend. So kind of distinction between the overall level of utilization and the level of growth of that utilization. There's really nothing in here that is inconsistent with prior reviews of this data. Everything we're seeing continues to support that. This iteration adds on 2 plan years, the 1920 plan year and the 2021 plan year. And again, seeing similar results to past data, if not even a little bit more indicator of sustained impact. So with that, I think we can turn to, slide 5 just has a summary. If you want to go back and take a overall look at the complete, 2008-9 to the 2021 utilization trend for OEB versus book of business for MOTA, and then for Kaiser OEB versus Kaiser book of business. Those are available for review, and then we'll walk through in potentially gory detail in each one of these categories. So we've got on slide 6 here, these detailed procedure slides. While they look a little scary, they're not that bad. They really are just comparing our utilization trend prior to the ACT implementation, the change in the year of implementation, and then a longer term utilization after that date. We've kind of called that date out. Generally, it's the 2010-2011 plan year. You can see it's kind of 3 over. We generally are trying to get an idea of what utilization was looking like way back then before we implemented. And then, taking a long-term trend view of what's it what utilization has been doing after. Generally, we'll have MOTA on the top and Kaiser on the bottom. We've got some differentiators in there in these two lines. The triangle with the purple line is generally OEB specific experience. The circle with the dark black line is generally MOTA's book of business, and that should follow both for the MOTA above and the Kaiser below. Okay, so trying to do a little color differentiation, but you can try and follow it by those shapes for the data points as well. And finally, you know, a summary table that really looks at all three of those time periods before the ACT, which is limited, the year of implementation, and sort of the longer term impact for all four of those measures, the MOTA OEB, MOTA Book of Business, and Kaiser OEB and Kaiser Book of Business. So for example, in the CT scans, you can see in the year one, we do have a material drop, you know, from above book of business to below book of business. But then, you know, we can kind of see, if you just eyeball it, you can see that long-term that's been running fairly consistent with book of business, you know, ending very, very close to the book of business there. And looking at that trend chart, the little chart in the bottom, you can put some of those eyeballs into actual numbers where we can see that the MOTA OEB trend has been about 1.8 and the book of business trend long-term has been 1.4. So kind of gives you an idea of close, but the OEB trend actually has been a little bit higher in this instance for this particular category. Looking down at Kaiser, we can see that Kaiser, you know, while it has had a higher trend, both for OEB specific and book of business, the magnitude of that utilization is quite a lot lower. Instead of running in the mid 70s to 80, running probably kind of from around the mid 40s up to the mid 50s in the last several years on a per thousand basis. Any questions on just the general format as we walk through? We probably won't walk through all of these slides. We'll hit a few of the key drivers in there and just to kind of key results. But if you have questions on the structure of the slides or the content, as well as the CT results, love to hear about that.
You know, this is Tom. I find it fascinating that they are equivalent. I'm trying to think of how CTs are used these days, and you know, it's would hospital and emergency department CTs be included in this?
I'm going to defer to Mark. I believe so, but
I believe they are. The data we received the data from the carrier, was extracted by them, and I believe it captures you know, total those facilities as well.
Okay, so if you show up in an emergency room and you're having a severe headache, you're going to get a head CT. You know, there's not a debate. You're not going to say, well, it's going to cost me $100. You know, it's the setting that becomes, you know, the way. So it was interesting how the ACT did make a difference. The way that medical practice has evolved, I'm not surprised that, particularly for this one category, that they're equal. The book of business and OEB's experiences are essentially equivalent. It's what's happening with the Kaiser Permanente data also. So there's some that and $100 for a medical copay. While $100, when you say $100, that sounds like a lot of money. I think people have gotten used to that. It's just a thought, but not one that we have to spend a lot of time talking about. I'm not surprised for this particular entity that it's changed to basically where the ACT had essentially no effect in utilization now, and what it's doing is just increasing revenue.
At that point.
Yeah.
All right. And any other questions on CTs before we jump to MRIs? All right, so we can move to slide 7. Thank you. So for MRIs, we do see a little bit different story.
I'm sorry, I had to push buttons to get back on.
There you go.
Sorry. So we're back up on a cost basis, but we also, what about triangulating average age or the number of people over certain ages, conditions? Seems like this program may still have an impact.
Yeah, very, very possible. We'll see, I think as we pointed out in the executive summary, we are seeing some sustained trend reduction, as well as I think sustained utilization reduction, as we'll see as we walk through some of these reports.
So those were both initial goals. Yeah.
Jeff, I was responding only in regards to CT.
Correct.
Which I think are used more in, cancer follow-ups and emergency room visits. I think we're going to hear MRI, and if MRI does show that reduction, I think there's more wiggle room for MRI.
Okay, thanks.
In terms of how they're utilized in a clinical situation.
Yeah, appreciate that insight, Tom. Absolutely. As we move to slide 7 and we look at the MRIs, we do see a little bit different story. We do see quite a large drop in the OEB utilization in the year of implementation as compared to book of business increase. And then generally we've seen the OEB utilization stay under book of business, both on a magnitude, and if we look at our little, put some numbers to the eyeballs in our chart, we do see that the long-term trend has generally been lower than the book of business. So, seeing some favorable results there. Interestingly, when we compare to Kaiser, again, Kaiser is lower in magnitude in general on a per thousand basis, but for OEB has had a higher trend overall, while the book of business has actually had a more favorable trend for Kaiser in total. So, any questions or comments on that? On the MRIs? Okay. Well, we can move on to slide 8, which is hip replacements.
This is Tom. My guess is that if we, just to support that conversation around CT and MRI, my guess is that CT is used to a higher degree for the combination of ER, hospital, and cancer follow-up as compared to MRI, which is being used a lot more for orthopedic type of stuff, where there is that give and take. Is it necessary versus not? Versus, you show up in the emergency room and you got knocked out, you're going to get a head CT. I mean, there's no question about it. If you have a head, you get a CT.
All right, do we have another question? I see a hand up.
I think that's Jeff.
Oh, that's Jeff. Okay. All right. Perfect. All right. Well, moving on to hip replacement, we can see that the OEB experience has generally been above the MOTA book of business experience. Although, while consistent, trend has been slightly lower in the long term. And so, measuring this over a period of so many years, that does, lead to some level of credibility there. Looking at Kaiser, not unexpectedly, Kaiser's OEB utilization has been relatively more volatile, but is also trended at a higher rate than the MOTA population. Although again, the MOTA book of business trend has run lower. So, all indicating that there may be some value to this ACT in a long run sustained utilization reduction. Okay, we can move on to slide 9, which is our knee surgery. In this case, our longer term trend has been negative, and both, larger and more favorable than the MOTA book of business, although the MOTA book of business trend has also been largely favorable. This is one where you can kind of see the eyeball happen, and those trends over time, very, very similar. If I had to make a guess, while trend has by the numbers been more favorable, I would say it's probably just been largely consistent with book of business in there. On the Kaiser front, Kaiser's trend has been negative for the OEB population, but not as favorable as the MOTA trend. But again, a little bit more volatile. Pointing out, again, on the Kaiser, very important to note that the magnitude of that utilization is quite a lot smaller than MOTA. Right. Can move on to slide 10, which is our knee replacements. Here in the knee replacements, we did see a very high trend pre-ACT. Hard to tell whether or not the ACT implementation moderated that, but we did see immediate moderation, and we do see longer term trend suppression than the book of business at 1.1% versus 1.8% for the book of business as a whole. So even though utilization is still up higher than book of business, we're seeing a slightly lower growth rate in there. And then from a Kaiser perspective, much lower than Kaiser's OEB experience over the last number of years, long term, but again, still higher than Kaiser's book of business trend in total. Okay, any questions on that? We can move on to slide 11 with shoulder surgery or arthroscopy. For this category, OEB's experience has been fairly close to the book of business. This is another one where we can kind of run our eyeball and see very similar changes, with the exception of the 2017 to 2018 plan year. And in fact, the last 3 years we've seen ending almost equivalent with the book of business. That said, given our higher starting point, we are seeing a larger negative trend for the OEB population than book of business, and larger negative trend than either the Kaiser OEB or book of business population.
Brad, this is Tom. The question that I have for both the shoulder and the knee arthroscopy, is what's included this is just the diagnostic scoping. Let's say someone had a knee arthroscopy and had a surgery to their meniscus. Would that be listed as knee arthroscopy for shoulder arthroscopy if they had shoulder arthroscopy and also had a labrum repair? Would it be shoulder arthroscopy? Do you know?
I am not sure on that question, Tom. That's a little too clinical for my my knowledge level on this stuff. Yeah. And that's definitely a question that we can take back to
whether or not it's a diagnostic or a therapeutic intervention is I'm just trying to think, why should we be doing, is there any reason for us to be putting a charge on a knee arthroscopy and a shoulder arthroscopy? I'm just trying to figure that out.
Yeah, I think the intention was to say, hey, before you go in and you go to your orthopedic surgeon and they say, oh yeah, we'll just clean that out or go fix this little tear or something. I think the intention was to say, hey, let's try some physical therapy first, or something that's less invasive.
Okay.
Yep. Good question. Good dialogue too. Makes me wish my clinical knowledge was a little greater.
Yeah.
Any other questions? If not, I think we can skip past a couple of these to slide 14, where we'll take a look at spine surgery. This was another kind of key category for us that we have been exploring and looking at through both the board and the IWG. Longer term, this is again a place where we've seen fairly consistent performance with the book of business. We've seen a few years where we're higher, a few years lower than book of business. The last 3 years, we've ended a little bit on the higher side. That's reflected a little bit in trend, which has been consistent, but a little higher than book of business in this case at -3 versus -3.7 in there. Again, Kaiser experience being a smaller population is a little bit more volatile for OEB, but it is decreasing at a higher rate or has a lower trend, higher negative trend than the MOTA OEB experience. Okay. And I think that will be the end of the utilization pieces that we look at. There's other small pieces here and there, but I think those are our key drivers. And that leads us to the second part of the analysis, which is looking not just at utilization, but at cost as measured on a per member per month basis. And as we all know, of course, cost has two components. It has a utilization component and a cost per service component. Can get a little bit difficult to really evaluate, some of these because you have condition mix and severity mix within these categories. But, in general, this should provide us a good high level view of, kind of what's going on, particularly when we look at it over this many years of experience. In general, the OEB ACT category costs have been faring more favorably than book of business. We kind of got it down across all of these different categories. We were averaging at a trend that is right about 2% lower than book of business across these categories. If we kind of take a look down at the OEB trend versus the MOTA book of business trend, we can see that this favorability really happens at pretty much all of these different categories, and it has in fact improved since we looked at this data a couple of years ago. So just seeing even a little bit more favorability. We do know that this trend, to keep in mind, is all driven by a combination of lower utilization, as we've seen in the prior pages, but it also is a function of decreased unit cost or changing unit cost, and that does vary considerably by different condition categories, as we'll see in here. All right, so looking at page 19 here, or 18, excuse me, move on to CT scans, and we'll start with the CTs and MRIs and take a look at those. We did see a significant reduction in PM during that first year, consistent with our, kind of what we saw in the utilization standpoint. And we have seen a sustained trend favorability at 0.1%, from a PM perspective versus 1.7 for book of business. So even though book of business is performing well, we are seeing the OEB specific trend performing even better. Note that we do not have Kaiser PMs as comparison points. And so we'll just be looking at the OEB experience versus MOTA book of business in this case. So in this case, ACT, you would kind of have to say it does appear to drive some sustained incremental PM trend reduction or favorability. Whether or not, Tom, to your point, that is appropriate for the types of services that are being delivered using CT scans is, up for debate. Moving to MRIs, we see a similar, if not even more favorable result. We did see a both year one and long-term trend reduction compared to book of business. And again, ACT does appear to be driving some sustained incremental PM trend reduction with a
we need the next
overall
slide.
negative trend. Oh, sorry, 19.
There we go. Got it. Thank you.
Thank you. Yeah. So we see this kind of overall long-term trend of -2.9 compared to MOTA's book of business at 1.3, and we see the PMs that have been consistently lower than book of business and in fact widening just a little bit over time. Any questions?
How is this? Yeah, Brad, how is this influenced by these PMs by the actual cost associated with the additional cost here?
That these I believe are allowed costs, so there would be no reduction for that copay.
Got it. Thank you.
Mm-hmm.
So just to be clear on that, because we're capping the allowed costs, then the member is paying the diff and it goes towards their out-of-pocket max? Is that what we're looking at with ACT? Is that how ACT?
No, the ACT is really just saying, hey, if you want to get one of these services, for example, an MRI, we know that's a really high cost service, and a lot of the times may not be necessary. You may go into your orthopedic doctor and they say, yeah, you got this knee pain, it's been a little while, let's do an MRI on that and see if we can use that to help us diagnose the cause. And Tom may reach through and slap me because I'm probably not going to characterize this very well. But in general, I think there's other forms of lower cost, either X-ray or maybe CT, or you could go through and say, hey, let's go through and really try some physical therapy first before we do this higher cost procedure in that. And so they'll say, hey, if you really want to go get this done, it's going to cost you $500. So you kind of might want to talk about it with your doctor to see if it's really necessary or not. We do know that many of these MRIs that are done are just not really necessary from a.
It essentially though adds to the copay.
Understand, but that goes towards your out-of-pocket max, right?
Yes, it does. So you're right. In one sense, you could kind of say, well, if I'm going to reach my total maximum cost, which is I think a little bit different than your medical out-of-pocket cost, you could end up having a little bit more coverage, but a lot of the times, if an individual is really, pretty sick, there's a good possibility they might hit their total cost share. Erica, you can tell me if I'm getting my terms right or not, and or not. So, in some cases, it will have an impact, and Bill, and in some cases, it won't. A great example is in an HSA plan, would not have. It would just go right toward your out-of-pocket maximum.
And there's no differentiation in the ACT plan between medically necessary and optional?
I'll let Erica answer that, but I don't believe so.
Are you asking if the copay only applies if it's a chosen optional procedure?
Like if I don't know, I can't even think of an example. If a child gets hit by a car and needs the scan, right? That's not optional? Right.
Yeah. So we do go through those codes, and any of those types of codes would not pull an ACT copay, but the majority of them will. But when it's for circumstances such as a car accident, something like that, you are correct. It would not pull the ACT copay.
And Erica, is that like related to a trauma code or something like that?
Yes, correct.
Okay.
But if you had cancer and you're getting regular CTs to see how your cancer is progressing, that's not an uncommon measure. You would continue to get that additional cost here for your CT.
Yeah, and I'm not positive about that one, Dr. Siltabo, but could definitely check to see if we pull out those types of codes as well.
Okay. It becomes a slippery slope. What you talked about, Bill, is the essence of the issue. Is we're trying to prevent the unnecessary utilization, and yet how to define that is difficult, and so you include it all.
If I understand your last example correctly, we're unintentionally or maybe intentionally diverting some of the cost of the higher cost member to the higher cost member, right?
That's the end result. The idea, the conversation back when the ACT was being implemented was as Brad started, he used the term preference sensitive procedures. So the preference and where there are alternatives in terms of how to proceed, and the issue is the physician and the member asking for the higher cost thing first as compared to doing it in a tiered way. So the idea was to put some road bumps, some bumps in the road to slow it down and those were financial. So, again, I personally, I was representing Kaiser Permanente at the time of the ACT. I didn't think it was a very good idea. And yet I was able to convince the board at that time that Kaiser Permanente's integrated delivery system had mechanisms to address the issue of utilization in different ways and did not need to be included in this. Think of all the wonderful things that MODA has been doing since to try to be much more surgical in its approach. So the issues around imaging now is trying to get people to go to the still high quality but lower cost places. Those are the types, I think, interventions that are being the ACT was a pretty blunt instrument, and it raises all the issues that you just raised around it's not very particularly preference sensitive when you've just been run over and you need, you're in the hospital and you need a scan to see, how many of the bones are busted or something, being silly in my example, but or if you have your cancer, you're being followed on a basis based on protocols and things like that. So, but that's the reason, the reality of what Brad, I think, is showing us is that indeed there are some elements of MRI that are preference sensitive, and by putting an additional cost to it, and I don't know if the cost for MRI is 500 or 100, but it definitely, by doing that, has, sure looks like it, there's an impact. The question is how many people actually are part of the preference sensitive where it was appropriate for us to do it versus, as you just described, moving costs to higher utilization, higher need patients. And that's a really difficult one to try to figure out.
When this got put in front of me 2 years ago, because I had not seen it before 2 years ago, I struggled with it, but didn't have enough time to digest it. It was fresh, and now I'm looking at it again 2 years later, and I'm really struggling with it. Right, but I see its purpose. I get its point. I think it does a lot of unintended things.
Yeah, that's the issue. Jeff, you had a comment?
Well, I'm curious, Tom. At the time we put it in, we didn't have the 360 program. We didn't have the degree of organized systems of care.
Got it.
And so how do we go about analyzing this to see whether it has run its course?
Yeah.
Because maybe we are justified in discontinuing that.
Yeah.
But not on the basis of this slide.
Yeah. That is, I think, there are other ways to get at inappropriate utilization or preference sensitive stuff.
I think a great example of that, Tom, is the work that's going on in the COE for joint surgery.
Exactly. Yeah.
And
exactly.
sometimes there's new vendors out there and things. There's new programs for second opinion services that are intended to do just that.
Yeah, it is, and we haven't dropped it. And Ali, I see your hand. Well, I'll have one short comment, and then you're next up. I think the reason that we didn't drop it before was because its impact on rates.
Sure.
And number one, and number two, the reason that we didn't drop it over this last year or two was that these issues are being addressed by the innovation work group. And so if we're going to make a change, we should do it as we roll out something else that will take its place. So that, again, my comment. So I have Ali first and then Robert.
Well, let me finish my hand and
Okay,
I'll
I'm
take
sorry.
it off.
Yeah.
So
Thank you.
I'm just going to recommend that we follow up on this subject in the next CL meeting.
Okay.
I was just going to make a quick suggestion. This sounds like a perfect issue for the health equity work group to look at, to really determine if this is really being applied equitably, especially as you said, as coverage has kind of morphed over the years. Even going beyond the cost analysis, I think we want to make sure that it is
it's a good idea.
And benefit.
Yeah. Robert.
Yes, I just wanted to say I really appreciate the conversation around this. I know it's like Bill, it's something that I struggled with in the past. I kind of let it go because of the other things that were going on, but I really appreciate the conversation we're having on that now.
Yeah.
We will add it to the work plan. And yeah, we'll add it to the work plan. And because I think that, and the issues are equity and its impact and unintended consequences.
Yep.
And we'll have to figure out how we can consequence. So Erica, it would be very helpful for us to see whether or not you have that MODA has any qualifiers that move people outside of the ACT. So you described earlier that for imaging, if there's potentially a trauma code and a hospitalization, that moves them out. And potentially, the issue was for cancer, people with cancer diagnoses, are their scans are they excluded from the ACT? So if you could do some research of that as we prepare for the fall and looking at this again.
Thanks.
Does that capture the committee's concern about the ACT and the things that we need to look at? Unintended consequences, the equity issues, and whether or not it actually does have impact. I know that Brad, probably less important to look at each of these individual ones would be to move to the impact on the cost implications. How much money is generated by this, and if we just immediately dropped it, its implication for rates.
Mm-hmm. Yep. All right, we can certainly do that. Why don't we go ahead and move on to slide 29 really quick. I'll tell you just as a quick interlude, looking at knees and hips, they do show a sustained PMPM cost reduction, but when we dove a little deeper, that was an instance where it did look to be more unit cost driven than utilization driven. Yeah. So there is a combination of MODA managing those unit costs or service mix or severity mix over time, but there are some of these that are driven by unit cost as well as utilization. But just from a real dollar perspective, slide 29 can kind of show the history of the copay offset to plan costs. So this would be basically a cost shift from the plan to participants. So we see in the first year of implementation, we had about $3.4 million of copays that were received by the plan to offset plan costs. That has dwindled over the years to about 1.4 and recently climbed a little bit to 1.5 million. So that is not a large cost result. That would be, I think we've got a little note down in here of about, maybe a fifth or a quarter of a percent impact to rates. While we're talking about rate impact, I think the larger impact could potentially be if we had a little spike in utilization. I know MODA has talked about that in the past. Not sure if that would really happen, but I think it would be worth doing some sensitivity analysis on that to see, hey, if we did have a 1% increase in utilization or a 5% increase in utilization, what could that do to our costs in the future years? And then you can kind of see on slide 30, this gives you an idea of the copay revenue that we saw sort of broken out by different cost category, different categories. And so we see that indeed advanced imaging.
Can we have the next slide?
Oh, sorry about that.
Thank you.
We do see on here that advanced imaging is the largest driver of these cost sharing dollars or the copay dollars at just a little under 400,000 on each one. I did check, and I believe they are both $100 copay, not a $500 copay. So, but still, that means there's a lot of services that are being done that are being, that have a copay associated with them. So, this would give you a feel for if there were certain types of these ACT categories that you wanted to remove. For example, if you wanted to say, hey, I think I'd like to discontinue this for CTs, but keep it for MRIs because there maybe is a higher chance of having preference sensitive MRIs than CTs. This would give you an idea of the plan cost impact just from a cost share perspective, not including any utilization impact that's potential there. My own feeling is that you probably wouldn't have, I think it was mentioned a little bit earlier by folks that there was a pretty good decrease in utilization. My experience in some of these programs, particularly under like the pharmacy arrangements, once you establish behavior patterns, they don't always just slip right back. So there may be some pop up, but I don't think it would be equal to the decreases that we saw early on in program implementation. And that also, then also is the consideration that I think over those 10 years, we've had significant advances in utilization management, health management, general plan management as well. Any question on slide 30 or 29? Kind of the revenue aspect, I think somebody called it, from the copays.
So it looks like the two advanced imaging, MRI and CT, result in pay for or at least 50% of the copays that are generated by this.
Correct.
Okay. And so in particular, it'd be very helpful for MODA to see whether or not there are any, what are the exclusions to where members are not being hit with that additional cost, the additional $100.
Okay.
And Ali, when you talked about wanting us to look at it from a health equity lens, were you looking at the using the health equity tool, or were you looking at just seeing whether or not MODA can look at the utilization of those two things. Let's just take, the high volume and high cost, which are MRI and CT, having them look at, I don't know, at utilization by race and ethnicity. I don't know how we do that, but.
Yeah, I mean, it's a really big part of the PEV program as well. So maybe it's something for the joint health equity committee to discuss.
Yeah. All right.
Strategy.
I think that's fair. Yeah. So let's move that conversation to the health equity committee. You'll do that. You and Damien will make sure that gets transferred over. Okay.
Yep.
Okay.
Okay. And, Tom, I think that can wrap us. We've already talked about sort of next steps. I think those are better next steps than we have in there, which is, looking at the COE and continuing monitoring and things like that. But I think it is, safe to conclude based on the data that we've seen, particularly in the last couple of years, that there may be some impact to this, that it may have driven some sustained cost reduction and trend reduction.
Right. Yeah. I'm not. Wouldn't be surprised if it. I think your data shows that there's been some impact. The question just has to do with, is the ACT the best way at managing costs?
Yep.
And
agreed. That is a very good question.
Yeah, I think that's the question, and looking at advanced imaging would be. It's sure is the one that jumps out. Those two are the ones that jump out. Yeah. Any other comments from the committee?
I just have one more wonderment, I'll say, not really a question. Well, maybe a question. So ACT kind of was a surprise for me when I was new here. We talk about at the rate-based summaries that we do in March and April, just basically the changes. We talk about co-pays and things of that nature, but we don't, if something doesn't change, we don't talk about it. We're only looking at the rate things on anything that's changing from whatever the current service level was for the previous year. So things that aren't changing, like ACT, don't get discussed at the board when we're just seeing, okay, what are all members having to pay for? So at some point, just see some kind of summary to the board on what is all the things that contribute to out-of-pocket expenses, instead of, so we get that list. ACT would fall under that. We don't talk about ACT because it doesn't change, right, during the rate sessions. What else is there is just I'm wondering.
Yeah. Are there other surprises? Your question is, are there other surprises out there?
And I will say, Bill, that we did chat a little bit about ACT in light of the out-of-pocket maximum change that was adopted for the 2022-2023 plan year. And so, recall we did eliminate the maximum cost share, if I'm getting my terminology correct, and such that now all of these ACT copays will be applying to the general medical out-of-pocket maximum limit. So there is some change that impacts the ACT, and that changes, I think, does mitigate the impact of the ACT copay to saying, hey, here's an upfront thing to make you stop and think, but if you really are using a lot of services this year, you're probably gonna you probably would have reached that maximum now anyways.
So first, my question was just, is there what else contributes to out-of-pocket, for our members? And then the second thing that kind of I chuckle at now, but it wasn't a laughing matter when I went to the ER about 7 years ago, doubled over because my gallbladder was attacking. And the CT scan I got in the ER wasn't an option. I didn't have time to think about that payment, right? Nor,
100%.
and it turned out I left the ER with 0 diagnostics. And then the following month, when I had another gallbladder attack, it was resolved and diagnosed with an ultrasound, which was next to free. But that was not an option in the ER, right?
Yeah, I totally agree with you on that.
Yeah, it's this concept around preference sensitive, and when you're, as you described your first attack, there was not much preference going on, was there?
Right.
Yeah. Okay.
We didn't say let's call the insurance company before I jump in. They sent me into that room. Right.
Yeah, exactly. Okay. Any other questions or comments from the committee? Okay. Thank you very much, Brad. Again, wonderful presentation, and you have sure appreciated all of your work and clear insights, and it's been a wonderful working with you.
Yep, totally agree, and really happy to have been able to help serve the board a little bit and have some fun along the way. Thank you, guys.
Thanks.
Yep.
Thanks, Brad.
Yep.
Okay, we have one more topic, and that is we have public comment. So if we can, Rose, if we can go to the public comment.
This may take me a second because Glenn changed the slides and took it out. So let me look. Okay, hold on.
Yeah. And if not, I'll just start talking because I know the topic relatively well.
Okay.
We have oh, did you find something? Or I'll just talk, and if you find it, that's great. We have a member who ended up putting in a comment to us around prevention services, specifically in regards to skin cancer screening by a clinician. As many of you may know, the Affordable Care Act included a requirement that private health insurance plans had to cover a list of prevention services at no member cost share, and the member was complaining that while our health plans covered while the health plans cover cancer treatment, it did not cover preventive skin screenings. And he said that this needed to be done by a specialist, a dermatologist, my assumption, and that because it wasn't covered under the prevention area, it was cost prohibitive, and wanted us to look into it. Excuse me. So that's the issue that the member has raised. The little bit of work we've done since the person raised this issue, I've looked at the ACA required the private health plans, of which our plans are part of, no member cost share for prevention services that have an A and a B rating by the U.S. Preventive Services Task Force. That's an arm of the government where they get experts who look at evidence, and if there's evidence that the benefit outweighs the harm, it gets this A or B rating, and health plans are required to cover. In 2016, skin cancer screening by a clinician was reviewed by the task force, and it was given an inconclusive rating. Inconclusive means that, one, there isn't evidence that shows that it reduces morbidity and mortality, and two, while small, there is a risk for harm in regards to unnecessary biopsies and potential functional problems from aggressive biopsies. So from a standpoint of the ACA, there's no requirement for our health plans to cover preventive skin screenings. The question that needs to go to the board is, does the board have a policy around prevention screenings and how we're going to cover it? Ali has looked and doesn't think there is a specific policy, only that we follow the law, and our health plans are required to follow the law, which would be A and B, and this one would not be hence would not be covered. But so we're going to look at that. We're going to do some research into this. And it wasn't that we're going to spend some time during the summer looking at what our policies are. I wanted just to raise it to the committee basically to respect, in a show of respect to the individual who raised the issue, and to let him know that we're on it, and we're going to try to find whether or not we have a policy, and then the board should probably SEOW can discuss whether or not we want to recommend a policy to the board around whether or not we expand beyond what the ACA has. The ACA, we don't get to pick and choose. If it's an A or a B recommendation prevention activity, the health plans have to cover it at no additional cost. So that's my take on this request to date. And we've communicated with the member that we are going to spend some time looking at it. Is there any discussion or comment from Ali? Did you want to add anything to what I just said?
No, I mean, sometimes things look kind of like a slam dunk, but, there's really a lot that goes along with some of these decisions. So I think, taking the right steps and being deliberate about it is the right approach. But again, I mean, I think this goes back to the previous issue. This is why it's so important for members to bring issues to SEOW or the board's attention, because it really puts a spotlight on some issues that we may not be aware of or haven't really looked at in several years. So applaud the member for doing that.
Yeah, agreed. Any other thoughts or comments?
Can I ask one clarifying question?
Yeah.
If my GP does a skin cancer screening, is that allowed? It's only not allowed if it's a specialist, or is it just not covered, period?
It is covered as all these things are covered as medical services. The question is, if you went in for only that bill, whether or not you would get, and you had MOTA, or actually either health plan, would you have a copay? And again, if it's an A and B recommended prevention service, there is no copay associated with it. So the person who has the woman who has the mammogram between 50 and 74, there's no cost share or member cost for that procedure, because it's an A or a B recommendation. The recommendation does not outline whether or not it's who does the procedure, only that they're a licensed healthcare provider.
So it's independent of that. Okay, that's what I wanted to clarify.
Yeah, it is independent of that. Yeah.
Got it. Thanks.
But what, yeah, I'll leave it at that. Okay. So that's the member comment that we will, as Ali says, we will really look at and make sure that when we come to some conclusion, we do it in a way that that is, one, thoughtful, follows the rules, and probably for the board should be looking at this and really being specific in terms of what it's going to, there may be a situation where we've decided to cover some prevention service that's not part of not cover isn't the right word, to do it where there's no member cost share. We have to make sure that, you know, we're consistent across our approach. Okay, so if there are no other comments, I think we are in conclusion of our SEOW meeting for the month of June. Rose, could you keep on? I want to talk with you about what I want during my report. Okay?
Sure.
All right. So thank you all.
Thank you, Tom. Great job.
Yeah. All right. So Rose, I